Yeah. Good afternoon to all of you. Uh, Sanket asked me to take some classes on hepatosplenomegaly. So I thought I'll start with hepatomegaly and then ended up doing a class on cirrhosis uh, because I thought it was again vast. And then I promised him that I would do a class on splenomegaly. And we thought we would do this clinical class on splenomegaly. But when I looked at this topic and went into it, I felt like this. It is just too huge to be covered in one go. And that is why I thought that I narrowed it down and I came down to the topic of massive splenomegaly. This is because this is something that's always kept for you in your exam. And I remember as an examiner, when we go around, we ask, is there a case of big spleen? Put it. We can discuss so many things. That's the examiner's attitude. And of course, it's a diagnosis that we come across quite frequently in clinical practice also. So I thought we'll just stick to massive splenomegaly in this class and then go for other causes of splenomegaly in another class so that, whatever we discuss it in depth. Again, this is an interactive class. It's a case-based, topic-based discussion. So the quality of the discussion depends on your interaction. You have to come up with answers on the chat box, and based on your answers, the next questions will be asked, and that's how the discussion will go on. So I just hope the postgraduates who are listening here are active, and the more you answer, the more questions will be asked, and the more answers will be given. So it's a something that increases in geometric proportions. Okay, so let's begin with the first bland statement. I'm just going to begin like this. A 55-year-old man comes with tiredness. On examination, he has a large splenomegaly. Now, I'm not going into this definitions of massive spleen, whether it will cross umbilicus, more than 8 centimeters. You can please check whatever book you want and this thing, but we all know what's a big spleen. And we will talk about those causes only here. So let's assume a 55-year-old man has come with a big spleen. So how do we go about it? So what I want you to tell me is, what are the common symptoms of a massive splenomegaly? Can you please answer on the chat box? What are your symptoms of a massive splenomegaly? Symptoms due to the spleen itself. That's what I'm asking. Okay. Somebody said abdominal discomfort, abdominal fullness, pain in the abdomen, early satiety, decreased appetite. Fair enough. That is because of the simple size of the spleen pressing on the stomach. You get the early satiety, etc. Bleeding manifestation need not always be there just because the spleen is big. Okay. Just because the spleen is big, what would you get? That you would get, like what you said, early satiety and things like that. I will just, okay. So fullness is something that you all said. People sometimes come and tell you they notice a mass in the abdomen. They feel that there's something sitting there and they can even feel it. And somebody has come, patients have come and told, doctor, I'm feeling something here. The dragging sensation is one thing that many people complain about because of big spleen. Something is pulling them on the left side. Can't eat because of the pressure on the stomach and the weight loss. And of course, you have pain because any massive spleen can outgrow its vascular supply and you can get an infarction and is prone to trauma. Okay, so you can get a traumatic rupture of the splenic capsule when you have a big spleen and you walk around. After all, your spleen is supposed to be inside your rib cage. It's protected, right? It's not supposed to be out in the abdomen and vulnerable to any trauma. So those things can come, and all of them are the symptoms of a massive splenomegaly, and they will cut across all etiologies. So this is something that's common across etiologies. Now let's get more specific. Now, what's the next history you want to ask? Somebody, 55-year-old man, big spleen. What do you want to ask next? What's the next history you want to know? Okay, somebody said fever. Okay, where he is living, residence. Go on. Anything more you want to ask? Anything more you want to ask? With a big spleen. Okay, weight loss, blood transfusion history. B symptoms, anorexia, weight loss, etc. Okay, fine. Okay, we'll pause there and let's look at what we asked first. Okay, first thing we'll ask is fever. Okay, and remember, this fever has to be long term. After all, you cannot get a spleen in a day, right? So fever and the spleen have to be there for a long time, and you're looking at infective causes. And among the infective causes of massive spleen, remember, I'm confining myself to just massive splenomegaly. I'm not talking infective endocarditis, typhoid, rickettsial fever. No, I'm not going anywhere near that. I'm talking of a large splenomegaly. If you look at the causes of a fever and a large splenomegaly, you got the Kalasa, you got the chronic malaria, or the tropical splenomegaly syndrome, which is renamed as hyperactive malarial syndrome now. It's no more called as TSS. It's become a HMS. And of course, you can have fever in hematological malignancy, and of course, fever in conditions which are causing pancytopenia. So you got a spleen, you got a pancytopenia. Because of pancytopenia, you got a fever, right? So there are different ways in which you can look at a fever in a person with a big spleen. One is there's an infection. Second is it could be a malignancy. Third is it could be something related to pancytopenia. Regarding the infections, I already put up, you got only two major infections which are causing fever like that. But let's go on to the next one. That is Kala Azar. Of course, I haven't seen much Kala Azar in my lifetime because I've always lived in the south. Those of you who are from Bihar, Bengal, I think it's part of your life. So you see person with a large spleen and they have prolonged fever, weight loss, then hepatosplenomegaly, lymphadenopathy, pigmentation. You are familiar with Kala Azar. People can have, patients can have hypoproteinemia, they can have ascites, they can have pedal edema. Those are all your features of a Kala Azar. Of course, long term, because the spleen is long term and the fever is also long term. And I've just put up the treatment options for you to just run through. Okay, let's go to the next one. You have a hyperactive malarial syndrome, which you usually used to call as TSS or tropical splenomegaly syndrome. How are you going to make a diagnosis of that now? What are your criteria for that? Go on, please. What are your criteria for masses? Sorry. I'm not getting the chat box. Yeah. Okay, somebody said IgM positive. Okay. Anemia, thrombocytopenia, splenomegaly. Anemia, thrombocytopenia, splenomegaly, so many conditions, isn't it? Need not be, hyperactive malarial syndrome. How are you going to link it up with the malaria? If you want to say this is because of a malaria, recurrent malarial history, endemic area. Okay. Okay. Then anything else? There are some criteria put forward for the diagnosis of a hyperactive malarial syndrome. Remember, this is not, a direct malarial infection. It's an immunological reaction to the malarial infection, right? So if you look at your criteria for your HMS, the major criteria are that you must have a massive splenomegaly, okay? Look at the second criteria, it's elevated serum IgM. And this is anti-malarial antibodies that we are talking about, IgM. And clinical and immunological responses to therapy, which is a therapeutic trial. Regression of the splenomegaly by 40% by 6 months after the start of therapy. And high antibody titers of Plasmodium species can be there. And of course, living in an endemic area. So we'll start like that. The person lives in an endemic area, may or may not have much fever because it's an immunological abnormal response to the malarial parasite. How do you link it up to the malarial parasite? You're linking it up because you have the anti-malarial antibodies sitting there. They are the ones that are telling you that this is related to the malarial infection, correct? And these are IgM antibodies. And of course, you give a therapeutic trial and you find out that there is regression. Then only you can say that this is a HMS, previously called as TSS, right? So again, remember, though I said it can be there, sometimes you can have what is called chronic malaria, which can be recurrent attacks of malaria, but generally spleen need not be so large, whereas in the HMS, spleen is definitely large. So not much fever may be there in an HMS, though I put it down as one of the causes of fever, not much. It's an immunological reaction. Response to antimalarial is crucial. That's part of your treatment. I mean, that is part of your criteria. And what is the treatment you give, please? What's the treatment you give? or a HMS, what's the treatment? Yeah, anybody? Yes. Okay, chloroquine. Somebody said chloroquine. Chloroquine, proguanil, isn't it? Two drugs that have been used are chloroquine, proguanil. Remember, the treatment has to be long term. It has to be, months, 3 months, 6 months, and then you watch out for the regression of the spleen, and that's how you even confirm that this is probably related to the malaria. Okay, fine. Right. Let's go on after that. Now, we made one sweeping statement. We said that, okay, you got a big spleen, and you got a fever, it could be a malignancy. Now, what malignancies are we talking about? In a spleen, in a big spleen and a fever, and you think it's a malignancy, which malignancies are you talking about? Okay, somebody said CML, somebody said leukemia, lymphoma, Hodgkin's. Okay, fine. So basically the hematological malignancies, right? You basically remember it's all hematological malignancies. Okay, let's look at what our answers are and where we are right and where we are wrong. Right. So remember, it's hematological malignancy. Even in your Harrison's classification of a PUO, if you say, how do you classify your PUO causes? Infective, malignant, immunological, or collagen. Third one is malignancy, isn't it? Three big uh, pockets you put the cause of PUO into. So your second pocket is rheumatological, collagen, etc. The third one is malignancy. If you go on to malignancies causing fever, again, solid tumors are few. You don't get much fever in a solid tumor. You can, maybe you can get in a RCC, you can get in a hepatoma, etc. But it's the lymphomas and leukemias that will predominate. Okay, fine. So we are looking at hematological malignancies causing fever and a big spleen. Right. So you're looking at two criteria. Now, which lymphomas would you consider? Hodgkin's or non-Hodgkin's? Which lymphomas are you considering now? Which of them are you considering? Yep. People are saying Hodgkin's, not Hodgkin's. Both, both. Correct. It is both because it's a B symptoms of Hodgkin's, remember, and it is the part of an NHL, right? So in both you can get a fever. Generally, the fever in a lymphoma is not very high, not very high. It's a low-grade fever. It can come in a Hodgkin's with the B symptoms, and it can come in a non-Hodgkin's anytime in this thing. And both of them can have a big spleen. And when we go into the lymphoma discussion, I will talk to you about it. Now, when it came to leukemias, I found people answering CML, etc. Now, it's not common. Okay, fever is not at all a feature of a CML, and I'll explain to you why. Remember that in leukemias, fever comes when you have an acute leukemia. Fever is not a feature of a chronic leukemia, and we will explain why when we come to that. Okay, fine. So we are not really looking at leukemias here for a big spleen and a fever. We are looking at more of lymphomas. Okay, fine. Right. Let's go on to the next one. Okay, we talked about symptoms of pancytopenia, right? So we are looking at anemia, leukopenia, and then thrombocytopenia. Let's go a little in depth in that. Okay, you got an anemia. When does this anemia person with a splenomegaly or whatever cause, when does he go into CCF? When do they go into CCF? What does it depend upon? All symptoms in medicine depend upon the speed of development, isn't it? As long as you have an acute problem, you will be symptomatic. If you have a chronic problem, you're likely to be asymptomatic. Remember that rule in medicine. So we are looking at, an anemia, which is, chronic, may not have much CCF, but when it goes to say 4, 3 and all, that's the time when the people start getting CCF. Okay. So remember that many times you, even with a 6, a 7, you do not get much of CCF at all because it will be a chronic anemia with a large spleen. Okay. Like I said, the causes are, we'll come to it later. When we come to the leukopenia, okay, the one important symptom that all of us are looking out for, is the agranulocytosis, isn't it? Causing a sore throat. So when you're putting a person on chemotherapy, when you're putting a person on, say, neomarcazole, your carbimazole, what are you telling the patient to come back to you with when they have a sore throat? That's when you're saying, oh, please come back to me because we may have, agranulocytosis. But there's one important difference between a leukopenia with an infection and a normal person with an infection. What is that? What is the difference between an infection presentation in a person with a leukopenia and a person without a leukopenia, a normal person? What's the difference there? What's the difference there? Febrile neutral. Okay, somebody said that. Lack of fever. Please understand that though I said fever can come in, you cannot really rely on it because you can get a neutropenic person simply go into sepsis without the fever coming in at all. Okay, fine. So that's important to remember. Second thing, the absence of formation of localization, isn't it? You may not get an abscess. Even the abscess is an attempt to localize an infection. If you want to localize an infection, you need your WBCs there. If you do not have your WBCs, you're not going to localize that infection, right? So that's why remember that is why it gets dicey. It gets dicey because your leukopenic patient is not really going to look very sick. You're not going to have a high-grade fever, may not localize into an abscess, simply will disseminate into an sepsis. So that's why it's important to remember that these people with pancytopenia, though we say they can have fever, nothing prevents them from having a fever, but even in the absence of fever, just be aware of that. And the third one, okay, we said we'll have thrombocytopenia. Okay, when do these people with thrombocytopenia bleed? In general, okay, you got a 50,000, you got to say a 20,000 platelet count. Okay, I'm giving you a patient with not for the splenomegaly, I'm just generally telling in life. You got a patient with dengue, you got a patient with ITP, you got a patient with leukemia, you got a patient with malaria, you got one with scrub typhus. Who's going to bleed? Who's the person who's going to bleed among all this? The leukemia. Correct. Please remember that in infections and in many other conditions, for example, chronic ITP, people don't bleed, isn't it? Your target count, platelet count in a chronic ITP is never 1 lakh. It's always 30 to 50,000 without bleeding. Bus, that's all you need, right? So the point is that the type of disease causing the platelet count, the low platelet count, is also impacting the rule whether the person will bleed or not. So if you have a person who's got a low platelet count and is bleeding, then you must remember that it could be some sinister pathology. Okay, something like a leukemia, something else is happening there. Whereas most people with many of the infections, okay, less than 10,000, correct. We are all scared of dengue. We got a big dengue season in Chennai. We're all scared of that. Okay, but the point is that the etiology impacts the need for the person to manifest with the bleeding. The etiology is sinister. Okay, they can bleed even at a higher count. A leukemia patient can bleed even at 50,000. Okay, fine. Whereas a person with dengue will probably bleed only when he goes to 20 or 10 or something like that. So remember, though we say pancytopenia, all the clinical features that be slightly more nuanced in our approach to how they will present to us. Okay, fine. Now, all of you said a massive spleen, the second important symptom apart from fever we are going to ask is appetite and weight loss. So you got a massive splenomegaly and you got an appetite and weight loss. What are your possibilities? What are your possibilities when you have weight loss and loss of appetite with a massive splenomegaly? What are your possibilities? Okay, somebody says lymphoma. Then go on. Anything else? Anything else? NHL, the same thing. Anything else? So basically, what are you looking for? You got only 2 answers. I expected much more. Any more? Okay, fine. Let's put it up. We got lots. Okay, fine. We are looking for hematological malignancies. Okay. Even CML, I wouldn't put it as a very important cause of weight loss, but they can have. But the lymphomas, yes, you can have in hairy cell leukemia, and you can also have in a CLL, which can also have a big spleen. So basically, if you're looking at a big spleen and a weight loss and a loss of appetite, apart from the fact that the spleen is going to press over the stomach and cause, satiety and things like that, you're looking at a hematological malignancy. If the person is really sick and things like that, you are looking at a hematological malignancy. And these are your possibilities for a big spleen and loss of appetite and weight. So let's sum up the symptoms now. So when you have a big spleen, apart from the symptoms of splenomegaly, which is here, okay, then you talk about the fever, you talk about weight loss, loss of appetite, you talk about the symptoms of pancytopenia. And I haven't come to this, the anemia and jaundice, because I thought it's overlapping with the examination. And of course, symptoms of each disease, which we will talk about. So when you have a person with a splenomegaly, these are the first few questions that you're going to ask about. Okay, fine. The fever, the weight loss, the symptoms of pancytopenia, the features of splenomegaly itself, and then we go on to the anemia and the jaundice. Let's go on to examination. Okay, I put this up because sometimes we can all get mixed up. Okay, first confirm it's a spleen, because sometimes you can have a large, kidney sitting there. The undergraduate way of saying that you can't insinuate your fingers, you got a notch. The notch is something that's easily palpable. Okay, so you must all learn to get that notch on the anterior border, upper and this thing 2/3 and 1/3. You put your hand, you nicely get a notch. You don't have any complaints. I mean, you don't have any problems in diagnosing that kind of a spleen. You don't have. So that you see, and it will move with respiration. Kidney also will move with respiration. That's not a problem. But the point is that you must remember that get your first thing right, that it's a spleen. Okay. Now I made a statement that I'll put the anemia and jaundice later, and I'll come to the big spleen later. So what are your causes of a big spleen and anemia and jaundice? Let's have those answers, please. Big spleen, okay. You're talking of a hemolytic disorder. Somebody says portal hypertension, extravascular hemolysis. Of course, it's extravascular. Malaria, that's a chronic malaria or a HMS. Okay, fine. Right. Okay. Let's look at what causes we have. Okay, so we are looking at a hemolytic anemia, but among the hemolytic anemia, not all of them will qualify for a big spleen. Okay, I've just picked up few. One is the thalassemia, the other one is the spherocytosis, then the autoimmune hemolytic anemia. Okay, and we will go into what symptoms would they have. General symptoms you all know. Okay, features of fatigue, because of anemia, things like that. And then you have a mild jaundice, which may or may not be noticed. Okay, fine. And of course, you can have an anemia CCF, you can have things like that. Okay, and each of them will have some symptoms, which we will go into later. So when you come to your examination, you're looking for an anemia, jaundice, splenomegaly. Of course, undergraduate teaching, anemia, jaundice, splenomegaly is equal to hemolytic anemia. Okay. So if you have a jaundice, okay, you're thinking of hemolytic anemia, but where I want to ask you is, will cirrhosis come in or not as part of massive spleen and jaundice, and will it cause a massive spleen or not? Does it cause? Somebody said yes. Okay. Somebody said no. That's nice. Portal hypertension with hypersplenism. Yes, no, yes, no. Okay, we can go on and on. Right. The point is, it's yes and no. The answer is right. Okay. Most of the times, it's a no. Please remember, the splenomegaly in adults with cirrhosis is never very large. Okay, it's never very large. Okay, it's usually moderate. Okay, it's only in kids that you have a very big spleen because of splenomegaly cirrhosis. And of course, you're looking for, a cirrhosis is easy to recognize. What's your problem? You'll have a jaundice, then you have a ascites, pedal edema, spleen. Okay, fine, that's cirrhosis. That's how you look at it, right? But in an adult, usually cirrhosis will not confuse you at all. Okay, and you're looking for the ascites structure. Okay, we'll talk about this again when I show you a case. And of course, you are going to look for an edema, right? So in a person with a massive splenomegaly, what is the cause of edema in this person? What is the cause of edema in a person with a massive splenomegaly? Yeah, anybody? Are we asking unilateral or bilateral edema? That's what you should have asked me. It's a unilateral or bilateral edema? Okay. Okay, somebody said anemia. IVC compression will not occur. The spleen will not come and sit over the IVC. It's not common. It's the ascites that can cause an IVC compression. Okay, then Hypoproteinemia. Okay. So unilateral edema, what will you think of? Unilateral edema, what do you think of? So big spleen, unilateral edema, what do you think of? Yeah? You think of a malignancy, right? You think of a malignancy or a hypercoagulable state, both of which can present with a DVT, right? So if you have a unilateral edema, that's what you think of. Bilateral edema, of course, hypoproteinemia, etc., etc. You can ask for. Okay, fine. So let's move on. Right. Okay, let's look at this case. Okay, 40-year-old lady presents with dyspepsia. Okay, on examination, she has a large splenomegaly, right? So she went for dyspepsia. Examination showed a large splenomegaly. She has fatigue. Hemoglobin 8.5, normal TC, normal platelets, no edema, no jaundice, no liver, no lymph nodes. What are your possibilities? So you got a big spleen, nothing else, okay? And yeah, this person, what will you think of? Somebody is calling hypercoagulable state. No, that's for the previous thing, right? So tell me for this case, what is the answer? Somebody says thalassemia. Somebody says PCC, hemolytic anemia, polycythemia, hemolytic anemia, CM. Right. Okay, fine. Okay. I will explain to you why. I know this is okay. I said no jaundice, glycogen storage. Okay, fine. We'll come to it. Okay. Now, this is one of my patients. I think I did mention this patient to you when I talked to you about cirrhosis. This is one of my patients whom I almost missed, right? Now, when you get this, okay, fine. The first thing you should do is to do an ultrasound, right? Because, and I told you, cirrhosis causing a large spleen is not common in adults. An extrahepatic portal hypertension can cause, okay, again, more common in children. It's not at all common in adults, okay. Extrahepatic portal hypertension usually in children is because of umbilical sepsis, causing a portal phlebitis, causing a portal vein thrombosis. That's how it goes. The other cause of portal vein thrombosis in an adult are your hypercoagulable states. Then you got some pancreatic CA, adrenal CA, some CA sitting on that, HCC causing portal vein thrombosis, etc., etc. Okay, fine. So again, that causing a big spleen is not common, right? So when you get a person with a large spleen, one of the things you should always do is an ultrasound. Get simple because you don't have a platelets, you don't have a low, high or low TC, you only have an anemia, right? You only have an anemia. And I'll explain to you why some of your answers which you said are wrong as we go by. But please get an ultrasound done and look for a portal cavernoma, look for a portal vein thrombosis. A portal cavernoma tells you that this spleen has been around for a long time. That's what it means. The spleen has been around for a long time. That's the time required to get those portal cavernomas. So when you get a big spleen and only anemia, this patient of mine had melena, but she did not know. She was not saying correctly. Then we put a scope in, we found the varices. That's how we made a diagnosis. So remember that this can fool us. When you're going on thinking all kinds of hematological things, the one thing that you should remember is get your ultrasound, clear the liver, clear that portal vein, and then let's get back to business. Okay, when I started by saying it's a 55-year-old man who's got a splenomegaly, and then I put up causes, and then I said thalassemia is one of the causes of big spleen. So what is odd about thalassemia as a diagnosis in this patient? What's odd about thalassemia? Okay, what's odd about thalassemia? The age, correct? The age, isn't it? We all know that thalassemia, nobody will live to 55 like that, isn't it? With such a big spleen. So that's odd. Okay, fine. So if that is odd, what could he have? He's not got thalassemia. Looks like thalassemia in many ways. What could he have? What are you thinking of? What are the other possibilities that you should think of? Let's lower the age for you. Let me make it say 35. What do you think of? No, doctor, nobody will survive even with blood transfusion to that age. Okay. So what are you thinking of? It's not a thalassemia. Looks like thalassemia. What are we thinking of? In an adult, something looking like thalassemia, splenomegaly, and most children, thalassemia is a disease of children. Everybody gets a big spleen even if they are a child, right? And they require transfusions to keep alive, etc. etc. But everything looks like thalassemia. Diagnosis also comes as thalassemia. So what are we looking at? No, it's a thal. I'm telling you it's a thal. So what is it? What is it? Oh, okay, I didn't put up the answer here. Okay. The possibility that you should think of is that this could be a sickle thal or a thalassemia intermediate, right? So in an adult with a big spleen, don't go for a thal major. Don't talk of thalassemia major. Don't talk about beta thalassemia major. Think of a sickle thal, okay, which can present, with in adulthood, or think of a thalassemia intermedia. Again, the terminology is changed now. I will explain that to you later. Okay, fine. Now, what would they present with? Like what you all said, anemia, jaundice, and of course, I'm not going to waste time on that. The bony features, the chipmunk faces, the malocclusion of the teeth, etc., etc. And of course, they can have, anemia and, failure, things like that, and a big spleen. That's what you would think of. And those are the other examination features, which I will again explain. Now, how do you prove that this is a thalassemia? What investigation do you do that this is a thalassemia? What is the investigation? Okay, looking for an electro. What are you looking for in the electrophoresis? What are we looking for in the electrophoresis? Chuma electrophoresis doesn't make any sense. What are you looking for? A2? No. What are we looking for? To prove a thalassemia, not in this person. F, okay. An increase in F, A2 is more for a thalassemia trait, things like that, okay, or a minor. That's when you're looking for this thing. You're looking, because basically thalassemia is a problem with the switching between the fetal hemoglobin and the adult hemoglobin. The switch gene is what is affected. So that's why you don't get the beta chains. Then you get an excess of alpha, and then you go for an hemolysis, and then the marrow is proliferating, and then you have, because it happens in a child and the marrow is amenable to proliferation. That's why you get in all the places where the marrow should be, still active, and that's why you get in the maxilla. That's why you get a chip on faces, and of course you can have extrapulmonary hematopoiesis. That's your pathophysiology of thalassemia, right? Okay, so you're going to prove it by, of course, you'll do a smear, and your smear will show microcytic hyperchromic teardrop cells, and then you do your LDH, you'll get an indirect hyperbilirubinemia, all those things Okay, I'm not going into that. The proof is by hemoglobin electrophoresis, but remember that in an adult who looks like thal to you, is probably got a thalassemia intermedia or a sickle thal. Okay, fine. So let's go on to the next one. Okay, what are your indications for splenectomy? Suppose I had kept a patient like this in the exam. That's what I'll ask you. Okay, this person has a spleen. When will you go and remove the spleen? What are your indications for a splenectomy in a person with thalassemia? Okay, somebody said Mentis index. Okay, fine. That's all right. Okay, go on. Yeah, when will you remove the spleen? Okay, how will you know that this person has hypersplenism? What's your first clue that there is a hypersplenism sitting there? Pancytopenia was late. It's late. Before that, the intertransfusion interval will narrow, right? The thalassemia patient who used to take it, transfusion once in 2 months, 3 months, he starts coming to you and asking for transfusion, dropping his hemoglobin. Remember, your target hemoglobin is between, say, 9 to 10. That's where you want to keep it, so that you don't want extrapulmonary hematopoiesis. So then your patient starts coming you at month 1. At 30 days, he wants another transfusion. He's dropping his hemoglobin. Exactly. So your intertransfusion interval narrows down. Okay. Hypersplenism is later. Okay, fine. Then you would go for a splenectomy. So many of the adults that thalassemia patients that we see are all splenectomized. They would have had a splenectomy for one reason or the other. Okay, fine. Right. So let's look at. Okay. The other complication. Can you name other complications apart from anemia, jaundice, hypersplenism? Okay. Tell me other complications of thalassemia. Iron overload, correct. Gallstones, right. Bony deformity, correct. Then, okay, okay, that's again iron overload. Then growth retardation, correct. Correct. Go on. There are many more. Okay, so I'll just share with you some of the things that I know. Okay, before that, let me just, this is what I wanted to show you. Now look at the terminology change here. Okay, look at this. Okay, this is thalassemia intermedia. It has become non-transfusion dependent and transfusion dependent. Can you see that? Now your thalassemia major is being called as transfusion. They found that, okay, it's because of the, the difference in the genotypes between the, thalassemia major and the intermediate. There's a difference. That's why you got the intermediate and the major. But now they're not worried about that. They're going to call you as transfusion dependent is the beta thalassemia major, non-transfusion dependent is your intermediate and your minor. Okay, that's one thing that I wanted to show you, that there's a slight change in the terminology. Now, my experience is what I'm sharing you here. We used to see a lot of thalassemics in Manipal, and we've got so many of them with iron overload come with cardiomyopathy, which is the worst thing that you can ever have. And then I've had people, because they're splenectomized, and sometimes they can come with infections. Of course, you're worried about the overwhelming pneumococcal sepsis into the OPSS is something that you're always worried about in any splenectomized patient. But even otherwise, other infections are common. Hypogonadism is something that can present with because of pituitary involvement. Growth impairment is something somebody you said. Gout you can get, vitamin D deficiency, and extramedullary hematopoiesis. Hematopoiesis going on elsewhere. Now, this is a case that we published in 2017. You can see that we had a spinal cord compression. Because of the extramedullary hematopoiesis in the thalassemia intermedia, we had spinal cord compression and we had to relieve it with radiotherapy. This patient came with paraplegia and recovered. Okay. So remember, there are many, many complications of thalassemia beyond what we usually say in the literature, apart from the usual complications of hemolytic anemia. Okay, fine. Let's move on to the next one, which we said as a cause of a large spleen. Okay, so we talked of spherocytosis, right? Spherocytosis, remember, can present with mild, moderate, or large spleen. Don't remember, unlike THAL is usually a large spleen, but spherocytosis is never like that. Okay, you can have a mild splenomegaly, moderate spleen, or a large spleen. All three are possible. So I want to ask you, what are the features of spherocytosis? What do they present with? Apart from the usual anemia, jaundice, what are the things that you want to ask about? What are the features that you want to ask about in a person? Okay, gallstones, correct. The very important presentation. In fact, many of them are discovered when they come for a cholecystectomy, right? They present with gallstones, and that is when you will go and discover that somebody does on hemoglobin. Oh, hemoglobin is low, physician consultation is given. That's when you discover that these people. So remember, spherocytosis, unlike THAL, is not transfusion dependent. People walk through life, and I have seen spherocytosis when they are having a cataract surgery. Somebody will call you saying that something is wrong with the hemoglobin. That's when you discover. So people walk through life with this, but gallstones and complications of gallstones are one thing that spherocytosis presents with. Okay, fine. And when will the anemia increase in the spherocytosis? When will they suddenly become more anemic than they were normally? When does that happen? In any hemolytic anemia, when do you think somebody will be discovered suddenly, oh, he's got a hemolytic anemia? When do you think that's going to happen? Okay, infection, oxidative stress? No. What else? What infection? It's a parvovirus infection. Any infection that suppresses the marrow, because remember, all these thalassemics and all your hemolytic anemia, they're living on the ability of the marrow to compensate. Once you knock that out, that is when your four crises. You got the aplastic crisis, you got the sequestration crisis when we talk of sickle. Okay, but remember that aplastic crisis can come in anybody. Okay, so that's why those are the times when they come out as hemolytic anemia, right? So your features are like any other hemolytic anemia. Gallstones is a very important feature. Now let's look at the other things. The important history, some of you mentioned, the family history. Why is it important? What is the inheritance? What's the inheritance? What's the inheritance? Autosomal dominant, correct. So that's why you can't go and take a history in a THAL, isn't it? Unless you have siblings and you have enough, you got 25% inheritance. This is 50%. The father or the mother is a person with a spherocytosis. But remember, spherocytosis can walk through life. So that's why they may not have been discovered. You may have to go and test them now. So that important history is the family history. Okay, right. Now, admitted for, like we said, cholecystitis. Okay, what about the ESR? What about the ESR in a spherocytosis? What's your ESR? Anybody? Osmotic fragility. decreased, elevated, high. Okay. So it's going for auction, right? Low. Okay, right. Yeah. Now remember, ESR is a very simple thing. ESR depends upon the ability of the RBCs to form rouleaux and fall down. And you're reading the ESR above the fallen RBCs. RBCs are down, your ESR 2 is like that. You're measuring above the RBCs, what is this thing? Okay. In a spherocytosis, the ability to form rouleaux is 0. Right? Because they are not biconcave. They're not going to stick to each other. They are like balloons. They cannot adjust like that and form a rouleau. Right? So that's why the ESR in spherocytosis is 0. Okay? So remember that if you have a 0 ESR, in any anemia, ESR should go up, right? Because the number of RBCs to sediment is less. Okay, so ESR will be high. In any polycythemia, ESR will be low. Lot of RBCs to sediment. The supernatant fluid is less. But in a spherocytosis, you have an anemia with a low ESR. So remember that in a spherocytosis, the RBC also is round and your ESR is also 0. Right, fine. Remember that always, right? And of course, you said, you're looking for spherocytes, which is what I showed you here. And then the other investigations are as usual, and you do an osmotic fragility test. This thing is fragile because it's already ballooned up. Little more hypotonic saline you put in, it will burst. That's what is happening to you. Okay, what do you want to do with this spleen? This man has spherocytosis and he has got this thing. What do you want to do with this spleen? You want to leave it alone? You want to do something else? What do you want to do? Okay, this is one condition where splenectomy is curative. Right, splenectomy is curative. Okay, fine. So that's why in any spherocytosis, you would want to remove the spleen because the person is kind of cured. Okay, fine. So this is one thing you will not hesitate about, and you can go ahead, especially if the person is symptomatic. I'm not saying just like that. Person is symptomatic, good to remove the spleen. Got a very good chance that the person will be all right. Of course, the usual precautions, you give your pneumococcal vaccine, watch out for those problems, etc., etc. Okay, let's go on to the next one. Okay, autoimmune hemolytic anemia. Okay, what's the size of the spleen in an autoimmune hemolytic anemia? I gave you as a massive splenomegaly. What's the usual size of the spleen in an autoimmune hemolytic anemia? Yeah, moderate, correct. It's mild to moderate. It's not at all an important cause of a massive splenomegaly. This is not something that you go first and say, oh, massive splenomegaly has got AH. AH is probably one of the last. Remember that. Okay, though I put it up, yes, you can get, that's why I put it up. But remember, that's usually mild to moderate in an autoimmune hemolytic anemia. Okay, fine. What kind of hemolysis do you get? What kind of hemolysis do you get in an AHA? Yeah. Okay. Extra, intra, everything is there. The spleen is enlarged, it has to be extravascular, right? But it depends upon what type of hemolytic anemia, AHA it is, right? Okay, but most of the time, okay, it's an extravascular hemolysis occurring in the spleen. So that's why you have got the types, you have got the warm antibody and the cold antibody. Two types are there. And the cold antibodies can be complement mediated, and that can happen intravascular. But the warm antibody is usually in the spleen. Okay. When will you look for an underlying cause? In an AHA, okay, you made a diagnosis of AHA, right? So when are you going to look for an underlying cause? Whom are you going to look for? Who is the person who requires investigation for an underlying cause? Okay, somebody said CLL. Anything else? Anything else? So basically, I'm okay, SLE. Okay, right. Basically, I'm asking you the causes of, apart from idiopathic, right? You got a whole set of this, you got the SLE, you got the CLL, you got the mycoplasma, you got so many drugs, isn't it? Hapten, so many things are there. So that is why you, okay, HIV, right? So many are there. Okay, fine. So remember that, especially if you get a 30-year-old female with autoimmune hemolytic anemia, please send your ANA. Please send your ANA, because SLE can be asymptomatic. Otherwise, SLE's aches and pains are all mistaken for hysterical women saying complaints. All kinds of rubbish goes on. So remember that in an AHA, 30-year-old female, always send your, because it has got implications. Otherwise, you're going to look at the kidney. It's a kidney SLE, you have to treat differently, right? So that's why. Okay. The complications of autoimmune hemolytic anemia, I won't go into it, but generally very severe anemia. You can get a metabolic acidosis. You can get a septic shock with them, and then they can die because of that. Okay. Investigation. What's your investigation? Direct or indirect Coombs? Direct or indirect Coombs? Direct. Okay. So DCT, right? It's a DCT. And remember, the DCT is a very sensitive test, positive in about 90 to 95, but you can get about 5% negative. Please remember that you can get, and you can get a false positive DCT when you transfuse, when you got other conditions. Okay. So, and an indirect can come if the AH is overwhelming, then you can get a direct plus indirect being positive, right? That can happen to you because this is after all a blocking antibody, but if the antibody is everywhere and so ultimately you're putting the anti-IgG and clogging it up, right? That's how you're doing your Coombs test. But if you got an overwhelming antibody, then you can get a direct, indirect. The antibody can be present not only on the RBC, can flow into the plasma, right? What is your indirect Coombs test? Plasma contains antibody. You take one dummy RBC, one O negative RBC, dip it into plasma, take it out, then do your Coombs test. Okay, that's all it is. So remember that it can come in many, many conditions. Okay, fine. So you can get the direct Coombs test being positive, small percentage direct Coombs test being negative. You can get an indirect, sometimes positive and overwhelming thing. Remember that. Okay, fine. Right. Treatment I'm not going to discuss. Okay, that's what I wanted to show you, that remember that extravascular hemolysis happens in the spleen. It is because of an IgG, whereas if you get an IgM and a complement, intravascular hemolysis can occur, especially in cold antibody, and it can be a different presentation. And that's a summary for you that I've taken up from a textbook. You can easily read it. So we said the DAT, and then we said about the causes here. So this is what we were saying, CLL, lymphoma, SLE, the drugs. And this side, again, you're saying the same things almost. The mycoplasma is an important, trick question that people ask. And of course, you're going to give a steroid, rituximab, splenectomy. And this side, you can give splenectomy and steroids are not of much use in a cold AH. But remember, autoimmune hemolytic anemia is not a very important cause of a large. Though I have seen patients with AH with the large spleen, but they are rare. Out of the under 200 patients, I would have seen 1 or 2 would have had. That's all. Okay. So remember that. Okay. Switch gears. Let's go on to the big spleen. Okay. Let's look at big spleen. Just looking at the time. Oh. Okay. Right. Let's look at causes of just big spleen. Nothing else wrong. Let's look at that. 55-year-old man comes with giddiness. He has a BP of 170 by 110, acid peptic disease also, large spleen. What's your diagnosis? Diagnosis. Yeah. Giddiness, big spleen. There is an acid peptic disease and there is a hypertension. Yeah. Anybody? Anybody? Sorry. Okay. I think nobody answered that. So I put up the investigations for you. 14.5 hemoglobin, WBC is 5,000 and platelet is 6 lakhs. Now diagnosis. CLL without lymph nodes is impossible. Polycythemia ET. Okay. Now look at this investigation. ET. Okay, fine. ET. Okay, right. Okay. Okay, fine. You're thinking of an ET. Right. Does ET have hypertension, acid peptic disease? Giddiness we can explain, hyperviscosity because of whatever, right? This we can explain. Okay. Right. Okay. Let me explain this. Okay. Your hemoglobin is okay. Your WBC is raised, your platelet is raised. That's where you're getting confused, right? So let me look at polycythemia criteria. Let's look at the criteria, right? Your definition of polycythemia is a HCT more than 49, 48, and 16.5 and 16. And of course, pan-myeloses, bone marrow source pan-myeloses. You've got all 3 elements going up, and your JAK2 mutation fine is positive, 95%. Okay, that we all know. Okay, if you look at the symptoms are those of, I'm talking of polycythemia, right? Let me take a polycythemia first. So headache, giddiness, blackouts, those are all because of your hyperviscosity. There's an aquagenic pruritus, which is a very interesting symptom, and the erythromelalgia, that's again the burning that you get, and of course, the gout. Remember, I had a patient with a uric acid of 10, and I was just thinking, why has he got gout? Just like that, and then the hemoglobin came up. And that's when I examined and I found a spleen. So remember, it can go backwards like that. Okay, fine. So remember, all these, proliferative disorders can have gout. Okay. The thrombosis can be arterial or venous. You know that polycythemia vera can present with portal vein thrombosis, hepatic vein, cortical vein. All these things can occur. So all these are symptoms. Now, where I confused you, I will show you. Okay, let's look at the investigations. We are looking at a high hemoglobin, which we said 16, 16.5, high HCT 49, all that. Increased TC and platelets also. We had this, right? But we did not have a high hemoglobin. Perfus smear will be crowded. ESR will be low. I told you, very lot of RBC sediment, very little supernatant. Erythropoietin low, variable. Not at all a very good investigation, isn't it? Only useful to differentiate between secondary and primary. Otherwise, erythropoietin is not of much use. Bone marrow, we hardly do, but it's a tricellular hyperplasia. We are usually going with a JAK2. JAK2 mutation positive, yeah, 75, 95% positive. Okay. What is this? What is masked PV? What is masked polycythemia vera? Okay. 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 So polycythemia vera without fulfilling the hemoglobin requirement is a masked PV. And this happens when you have either a blood loss or you have an iron deficiency anemia. All these things can come, right? So always remember that this criteria, what we are talking about, may not be that's why I put the 14.5, just to make you understand that there is an entity like this which can be missed. If you're only looking for the hemoglobin, you're going to miss it. Your big clue comes from your total count without infection, your platelet being high without having a blood loss. Now, what is that now, right? When you look at that, then you look at the 14.5 and then you find out this 9 deficiency anemia, it could still be a PV, right? Okay, fine. So the uric acid you can look for, and the ultrasound abdomen you look for. Okay, you basically look for a portal vein thrombosis in an ultrasound if you have a problem. Okay, fine, because it can cause portal vein thrombosis. It can cause any venous thrombosis, IVC thrombosis. IVC thrombosis, I've seen 3 or 4 cases with polycythemia vera with IVC thrombosis presenting with ascites, pedal edema, looking like cirrhosis, but ultimately turned out to be a polycythemia, right? Okay, and this is headache conversion. This is a cortical vein thrombosis. Okay. What other complications are expected in a polycythemia apart from the venous and arterial thrombosis and all? What other complications are expected? What complications are expected? Anybody? What will happen to polycythemia as you go by? Oh, thrombosis we know. Anything else? No, not much of CHF. They're always worried about only 2 things. What will happen to that marrow, right? They go into a myelofibrosis. It's a myeloproliferative disorder. It will all go into myelofibrosis, or it will turn out to be a leukemia. These are the 2 complications that you are always worried about, right? Okay, fine. So let's move on. Okay. Now, the secondary polycythemias, of course, smoking, alcohol, all those things, you can have a high hemoglobin. And remember, polycythemic fellows can also smoke. So if you want to remove that secondary component, ask them to stop smoking, etc. Come after 1 month, 2 months, and then repeat the hemoglobin and see. And Guy's box, which is polycythemia differential diagnosis. Please remember, stress, dehydration causing a high hemoglobin, etc., etc. Many times in dengue and all we see a lot. But remember, none of them have a spleen. So they will not come into a splenomegaly differential. They will come into a polycythemia differential, which could be secondary, which could be inappropriate erythropoietin secretion. There are so many causes. The ovarian tumors, so many other causes are there. HCC, all of them can have polycythemia. That's different, okay? That's not what we are talking about in this class because we're talking about splenomegaly, right? Okay. The treatment is phlebotomy. We want to bring down the target of HCT to 45, and then you have to remove this, etc. The drugs we use, I'm just running through it because it may be useful for you in the exam. These are all undergraduate slides which I made, so I'm just sharing it off. So hydroxyurea to decrease the splenic size. You can have interferon alpha and this NIBs and aspirin. That is very important. All polycythemic patients, okay, with some risk factors, even otherwise, we need to treat them. We need to prophylactically prevent strokes by putting them on aspirin. That's very important. And like I said, 2 things you always worried about. You are worried about a myelofibrosis. You are worried about an acute leukemia for all myeloproliferative disorders. Okay, fine. Right. Move on to the next case. 60-year-old lady goes for a routine health checkup. Platelet count is 6 lakhs. Okay, hemoglobin and WBC are normal. This is what we were talking about. This is your ET, right? Not the ET of Spielberg. This is your essential thrombocytosis. Now, what advice would you give this patient? What would you ask? What would you ask this patient to do? Leave him alone. Treat him with some drugs. What will you do? Okay, toxolinitive. Okay. Yeah, depends upon aspirin. Correct. Remember that. Remember, your aspirin is very important because you're always worried about the stroke. Okay. The clinical features of ET are presented with thrombosis. Paradoxically, ET can present with bleeding, especially if the platelet count is 10, 15, like that, because the acquired von Willebrand disease occurs only after a platelet count of, say, 9, 10, like that. It doesn't occur at lower platelet counts. You know that, isn't it? So remember that hyperviscosity symptoms are known for everybody, and there's this massive splenomegaly. Yeah, I hope you're all following what I'm saying, but I am talking at a second or third year PG level. Please excuse me, otherwise I can't finish, right? Okay. Reactive thrombocytosis. There are many causes. Can you just name a few before I put it up? Reactive thrombocytosis. Okay, I already put it up, right? So you got anemia, blood loss, very important. Your iron deficiency anemia, looking for a thrombocytosis. If it is there, you're thinking that patient doesn't know, but he's bleeding from somewhere, right? Infections, all infections can cause a reactive thrombocytosis. Remember that. And Sanket is very fond of telling me that rheumatological disorders will cause thrombocytosis. I learned it from him. Okay. So there are many conditions like that. Post-splenectomy, oh, I've seen platelet count going up to 15 lakhs and everybody worried what will happen to this patient now. This happens, right? And it will settle on its own, right? Okay, fine. So these are the causes of reactive thrombocytopenia, not relevant to a big spleen, but generally remember that every thrombocytosis is not an ET. It's not an ET, right? It's not a myeloproliferative disorder at all. Many of these conditions can cause, but they're never very high. Never like, 10 and all you won't get. Those are all most probably ET, right? Okay, fine. Treatment of this is low-dose aspirin. And if it is more than 15 lakhs, remember ET doesn't require treatment otherwise. More than 15 lakhs, hydroxyinterferon and anagrelide, because you want to bring down the platelet count. And there's no risk, low thrombosis, no treatment needed. Small percentage will go to leukemia. The safely you can write for all myeloproliferative disorders. Okay, fine. Right. Let's move on. 50-year-old housewife presents with fatigue. She's unable to do physical work since 6 months, feeling full on eating small amount. No fever, no bleeding. General examination, mild pallor, nothing else. Spleen, liver 2 centimeters, spleen 10, no free fluid. Clinical diagnosis. Clinical diagnosis of splenomegaly. Yeah. Splenomegaly. Yes. Yeah. This patient diagnosis. Only fatigue, big spleen. Nothing else is there. Somebody says CML. Any other takers for the diagnosis? What is HS? Myelofibrosis. Okay. Myelofibrosis. Okay. Portal vein thrombosis. Right. Okay. Okay, fine. Let's look at that. Okay. Yeah. When you get this kind of a clinical picture, you have to think of a CML, right? It is important to think of a CML. Of course, portal vein thrombosis, like I told you, but there's no anemia here. Nothing else is there. So that's why I'm not really thinking of. But a CML is a good possibility. Okay, fine. And let me tell you why. Okay. Let's look at this. Okay, right. Let's look at the investigations. Hemoglobin is 10. That's your TC. That's your neutrophil. That's your platelet, and everything else is normal. Okay, right. So, okay. Now, I want you to focus on one or two things in this investigation what I have given you. Hemoglobin, decent, isn't it? Not much anemia. Look at your platelet, higher, not low, right? Your total count, sky high, isn't it? Once you get a total count of more than 1 lakh, hardly any differential. You're not going to think of a leukemia reaction. All that is gone, right? So that's why remember nothing else. Okay. There's one favorite question everybody asks: what are the causes of leukocytosis without infection in medicine? There are so many causes. One of them is this. Okay. But you got a sky high count. But I want you to focus on this one. What is the percentage of neutrophils there? It's 80%, right? It's an 80% neutrophil. That's what tells you that this is probably a myeloid disorder. Okay, now let's go a little further. Okay, so I want to ask you, sorry. Okay, do they have infection? Do these fellows have infection? The CML fellows, will they have infection? Yes or no? Yes or no? Do they have infection? Yes. Yeah. Yes. Anybody? Okay. The answer is a big no, isn't it? Capital N and no. That's why I wanted you to see what is it that they are having. Okay, fine. Now in a CML, the predominant cell for you in that myeloid series is the mature granulocyte. It's the mature granulocyte, right? It's not the immature granulocyte, it's predominant. Okay, fine. So that's why infection is not at all common. Anemia is not common. Bleeding is not common. Remember, this is a chronic leukemia. It's not an acute leukemia. Okay, fine. And bleeding and thrombosis, again, not common, though your platelet count can be high. That's one of the features. I've had CML with a platelet count of 10 lakhs. They will have all the hyperviscosity syndromes and all that stuff. Okay, but it's not common, right? And I will explain to you why. This is what I said. The peripheral smear shows TC increase, 80% are mature cells. The cells, the predominant cell of CML is a mature granulocyte. Though you have the whole myeloid series out in the blood from the bone marrow, promyelocytes, myelocytes, metamyelocytes, bags, everything is seen. My professor used to say it's a college girl's appearance. Each one is looking different, okay? So each one is looking different. So that's why all those cells are out, but your predominant cell, what's your most important cell? It's a mature granulocyte. That is why infections are uncommon in a CML. They are uncommon. Okay, and platelets, remember, they are normal or they are increased. And there are no blasts. Okay, there are no blasts. If at all you get blasts, it will be 1-2% like that in the peripheral sphere. And you don't expect blast. If you get it, it's different. Okay, the bone marrow, this is the peripheral smear showing the presence of all kinds of cells there. And the bone marrow, which is hardly done, will show crowded with all kinds of blood elements of the myeloid series. You know the pathogenesis, the 922 translocation. You know the Philadelphia chromosome. You know the oncogene causing increased tyrosine kinase activity, uncontrolled proliferation. That's why you're giving your imatinib. That and all you know. So to sum up, it's a CBP with a very high this thing. No blasts are there. Okay, and the mature neutrophil is the dominant cell. Philadelphia chromosome, BCR-ABL copies are there, which is your oncogene copies. That when you do the CD markers, hardly we do the marrow. Okay. Now the treatment, as you all know, is imatinib for 400 milligrams. Look for hematological, cytogenetic, and molecular remission. This I think you all know. Bone marrow transplantation not done these days, and that is over. Okay, fine. Now let's proceed. So there's a CML patient. 6 months imatinib defaulted. Many of our patients will default. Then comes back with a huge spleen. Remember, when you put the imatinib, spleen will simply shrink back. It will go back into the costal margin. But this person has a big spleen and it come back because it's a defaulter, and then the hemoglobin dropped, the platelet dropped, the count went up, and there are myeloblasts. So obviously, this is a blast crisis. So remember, in a CML, you get your anemia and thrombocytopenia, which is significant only if you have a blast crisis. Otherwise, you do not get it at all. Okay. So CML has chronic accelerated blast crisis, and blast crisis is treated as a leukemia. Prognosis very good if you catch a CML, but bad if it's a this thing. Let's go on to the next one. Okay. Slightly tricky. I want you to think about this. 68-year-old man, big spleen, no lymph nodes, nothing else is there. We're talking only big spleen, right? So you got an anemia, you got a TC which is raised, you got a platelet borderline low. What's a diagnosis? What's a diagnosis? You got a TC 26, not very high. You're expecting the CML, 50,000, 1 lakh, like it, not like that. And you got an anemia, which is against a CML. Okay. Infection, why the anemia? And why the huge spleen? We're talking about a person with a big spleen, right? So we're not talking infection, right? Total hypertension. Why the total count? Okay, I won't keep you waiting much longer. I'll just show you what it is. Okay. One thing that you have to consider is a myelofibrosis. Okay. Now, why I put the total count high is initially You can get an increased total count, then it will decrease. Okay, the leukoerythroplastic blood picture, etc., whatever you're talking about, that's all because of irritation of the marrow, isn't it? It's a cytokine causing abnormal cytokines in the marrow causing myelofibrosis and increased fibrous tissue. But initial irritation can cause a higher count. So remember that part. You can get an anemia thrombocytopenia, but the total count is actually high. Okay, so myelofibrosis, marrow replaced by fibrosis, disease of the elderly. Remember, it's not going to come in the young people. Weakness, weight loss, massive spleen, leukoerythroplastic blood picture, initially high concentrated pancytopenia, dry tap in the marrow, biopsy is needed. Many times that is because you won't get a aspiration, and a JAK2 mutation can be positive, but not in PV, not like PV. PV has got 95%. This is about 50%. Okay, right, fine. Okay, and the treatment is again, supportive transfusions, hydroxyurea, splenectomy, and you got a bone marrow transplantation and your JAK2 inhibitor. Okay, okay. Let's look at, can it be an MDS? Can this be an MDS? A large spleen the fellow had, and this thing. The point to remember is pancytopenia is a feature of MDS. Spleen itself is uncommon, so we never make a diagnosis of MDS which a large spleen, and massive is never in favor. Okay, so remember that MDS, when you get a big spleen and whatever pancytopenia, don't call it MDS, call it a myelofibrosis. That's a much better diagnosis. Okay, right. Oh, sorry. So this is again 55-year-old man coming with massive splenomegaly, weight loss and pancytopenia. So it's not massive splenomegaly and pancytopenia alone. There you would have gone for myelofibrosis. Here you got a weight loss, and then your possibilities become the malignancies. So you got a hairy cell leukemia, you got a splenic marginal cell lymphoma, and you got hypersplenism. Remember, no lymph nodes are here. See that problem? It's only massive splenomegaly. Weight loss, pancytopenia. You're looking at the malignancies, right? Hypersplenism is just one thing that I put up because it can come, right? Okay. So look at hairy cell leukemia. You got a symptoms of a big spleen, you got a pancytopenia, fatigue, weight loss. Peripheral smear is enough. You can make out your hairy cells and your CD markers or those of a B cell. That's why you got the 19, 20, and 22, and your bone marrow is many times dry. And the treatment, cladribine and pentostatin and rituximab. That's your hairy cells which are there. So when you got a person who's older with weight loss, with a big spleen, remember that, and pancytopenia, remember that it could be a hairy cell leukemia, right? Where you put this splenic marginal cell lymphoma along with it is this presents with nothing except the spleen. That's why. Looks like exactly like hairy cell leukemia, but the diagnosis is made of the CD markers and it can be a splenic marginal zone lymphoma. That's why I put it here. Okay, right. Then you have the storage disorders, okay, which I'm not going to discuss in detail because they're more common in children, but can occur in adults. They again present with pancytopenia, hepatosplenomegaly, and they can have big spleens, and they're all storage disorders. The Gaucher's is reduced beta-glucosidase, and the Niemann-Pick's is reduced acid sphingomylase. They are lysosomal storage disorders. They can also present with pancytopenia, hepatosplenomegaly. The last one. What is this? Asymptomatic, only spleen, nothing else is wrong with them. No fever, no weight loss, nothing else is there, just a mass. A hydrated state or a splenic cyst. Okay, fine. So remember that a hydrated cyst or a splenic cyst can present with just a mass. Okay, so let's sum it up for you for a massive splenomegaly alone. Nothing else wrong with them. Your diagnosis is myeloproliferative disorders in which you get PV, ET, CML, and myelofibrosis. You got the hairy cell leukemia. You can add your mantle cell lymphoma there and the storage disorders and the cysts. Got that? So it's only a massive spleen, nothing else wrong. Then think of this kind of a differential. Let's get a little more complicated, and I think I will finish in Sanket, 10 minutes more.
Perfectly fine, ma'am.
Okay, right.
Yeah,
okay.
we are enjoying.
Yes. Okay, right. So yes, you got a spleen, a lymph node, and a liver. Okay, you got a big spleen, not an ordinary spleen. So big spleen, lymph node, and liver. What are your possibilities? Big spleen, lymph node, liver. Possibilities. Yeah. Anybody? Okay. Okay. Big spleen, lymph node, and liver. Okay. The lymphomas will come in as one major thing, right? Okay, this is where the lymphomas walk in with your thing. Okay, the other two things I put up is one is a CLL and one is sarcoid. Of course, the CLL big spleen can come, but a lymphoma will come way ahead. Okay, a sarcoid will come, but a sarcoid will have many other features. Okay, but remember, if you have a spleen, lymph node plus liver, think of a lymphoma, CLL, or a sarcoid. Okay, now which type of lymphoma? Somebody said Hodgkin's, somebody said non-Hodgkin's, but you got both, right? So when would you get it in a Hodgkin's? When you get a spleen in a Hodgkin's, which stage? Which stage of Hodgkin's do you get a spleen? Okay, it's a 3S. Correct, it's a 3S. Okay, remember the 4 becomes liver, pleura, pericardium, bone marrow, that is 4. Okay, whereas 3S is a Hodgkin's, right? Fine. So you can get it in Hodgkin's and non-Hodgkin's. In the non-Hodgkin's, it can come at any time, right? That's a basic difference between a Hodgkin's lymphoma and a non-Hodgkin's lymphoma. Hodgkin's has a pattern, begins on one side, right? So it has got a staging. You begin on one side, go to the other side, cross the diaphragm, then go to spleen, then go to bone marrow. That is Hodgkin's. Non-Hodgkin's, multifocal in origin. So everything comes up at the same time. That's why the non-Hodgkin's is more likely to present because the lymph nodes may not be there. You can get, yes, it's non-contiguous. You can get just a hepatosplenomegaly, not much of lymph nodes. That is a non-Hodgkin's. Okay, that's what you're worried about missing, because the Hodgkin's takes its time, it gives you the chance to do the lymph node, etc., but the non-Hodgkin's may not give you that kind of time. Okay, so it can come in Hodgkin's and non-Hodgkin's. Okay, staging is important in which lymphoma? Staging. Sorry. Okay, staging is important in Hodgkin's or non-Hodgkin's? Hodgkin's, right? Staging, because it follows one pattern. It's a regular guy. Staging is not important in non-Hodgkin's because it's all over the place. The other clinical features you have to look for: fever, autoimmune hemolytic anemia, other causes things. Non-Hodgkin can cause intestinal obstruction. You can get mesenteric nodes. Non-Hodgkin's will go everywhere. CNS, testis, everywhere it can go. Breast, everywhere. Pleura, pericardium, all those things can come. Right. So other investigations we need to ask are, you have to image the lymph nodes that you can't see. Right. The principle is the lymph nodes that you can palpate them. The lymph nodes that you can't see, mediastinal, intestinal, image them. Okay. And you want to see the pleura, you want to see the pericardium. Nowadays everybody does one PET and gets everything there. Okay. And you should remember there's an entity called mantle cell lymphoma which can present with a big spleen. Okay. Right. So yeah. Sarcoid, again, I'm not going to discuss the clinical features, but remember the clinical features are mainly in the lung. Okay, mainly in the lung, the bilateral mediastinal adenopathy, then you have the interstitial fibrosis, then you got the pleurisy, pleural effusions can be there, so many things can be there, and then lymph nodes, liver, spleen, and then erythema nodosum, and all this. So many things are there. Okay, I'm not going to discuss them. A big spleen is not the first thing that happens in a sarcoid. Please remember, it's not one of the things that you first think of like that, because it has got so many other things. But splenomegaly is a feature. Moderate splenomegaly can come. Sometimes it can be big. Okay. So I've seen a patient, I can never forget the patient. She had a big distension of abdomen and a big splenomegaly. Later on, we diagnosed a sarcoid. So the mediastinal adenopathy, had no clue. I mean, she was breathless. Everybody thought some weakness like that. So remember that you can present with the splenomegaly, and of course your hypercalcemia and your ACE levels will give you the diagnosis, and your treatment will be a steroid. Okay, let's go one more case. Okay, right. 75-year-old lady comes with swellings in the neck and axilla. On questioning, she's noticed it since a year. They are painless. She did not go to the doctor because they are there, but they're not doing anything to her. Multiple lymph nodes are the neck, axilla, inguinal region. Spleen is palpable, 8 centimeter, liver is 2. So what is this now? What is this? NHL, if they live 1 year, we should congratulate them, isn't it? So it's a painless lymphadenopathy. Yes, that could be a CLL, right? CLL is one condition. Remember, the chronic leukemias give you time. And of all the chronic leukemias, the one that gives you the maximum time is CLL. Because CLL patient can live for 10 years without anything, okay? Because they can have only the lymphocyte raise. Then they can have, 2 or 3 lymph nodes. The staging, the rise staging and the other staging that we have, all those things are based on that, right? So 1 year, lymph node, nothing happened to you. Probably you got a CLL. Okay, fine. That's why we have to think. Okay, right, fine. So let's look at. Okay, so look at the count again. The total count is this thing. And remember this again. say 80% lymphocytes, and these are mature lymphocytes. They're not lymphoblasts, okay? Not much of anemia, not much of platelet decrease. Chronic leukemias do not cause anemia and thrombocytopenia in a big way. They will get into that only when they go into a blast crisis. So diagnosis is CLL. And like my professor used to tell me, it's a schoolgirl appearance. All the lymphocytes are looking alike, right? All are looking alike. That's why he used to call CML as a college girl appearance, because all kinds of cells, and CLL as a schoolgirl appearance because they're all looking alike, okay? The bone marrow is flooded with lymphocytes, no blasts, right? Other features, autoimmune hemolytic anemia, liver, spleen, bone marrow involvement. And that's your staging. You got the stage A, B. Remember, many people are in this stage, only TC increased. They will run around from place where 25,000 count, IU, something is wrong with me, 80% lymphocyte, nothing else is wrong with him. He's probably going to die of a stroke or an MI later, not because of CLL. But everybody will be scared, okay? But remember, lymph nodes may be 1 or 2, okay? And no anemia, no thrombocytopenia at that stage. And the stage B is when lymph nodes are enlarged, and then you get the bone marrow involvement, which is when you get anemia and thrombocytopenia, right? Okay, fine. And I'm not going into this. Your stage A, no treatment is needed at all. Here you start fludarabine, rituximab, bendamustine, etc. And of course, this ibrutinib, which is your proton kinase tyrosine kinase inhibitor for relapse. Okay, I think I'm finishing. So let me look at this last slide for exactly 5 minutes and sum it up for you. When we looked at the causes of a massive splenomegaly, look at this side. All are hematological. Remember, everything is hematological, right? And your top things are hematological causes of myeloproliferative disorders. You got the CML, the myelofibrosis, the polycythemia vera, and the ET. They're all coming as one chunk there. Then you got the hematological malignancies, okay? When you get the weight loss, so the lymphoma, hairy cell leukemia, CLL, they all come there. And you can put your mantle cell lymphoma also there. Then you got your hemolytic anemias, out of which not at all common, except the thalassemia, which is in adults, a thalassemia intermediate or a sickle thal, or you can get an autoimmune hemolytic anemia rarely, and a spherocytosis, okay, you can get a big spleen, but these are not very important causes, but they can come. Go this side, you got the infections, chronic malaria, HMS, Kalasa, and then you got a sarcoid sitting there, and you got the extrahepatic portal hypertension, compensated cirrhosis. Remember, this is common disease, so you should rule it out before you go and jump into something else. Then you got your Gauchers and Niemann-Pick's, which are storage disease, and then you got your splenic cyst. The causes on this side are not very important, except that you should not miss this one. These are all rare causes. And this side, remember, a massive spleen is most often hematological. And in the hematological, you got the non-malignant conditions. In the malignant conditions, the non-malignant conditions are the myeloproliferative disorders, and you got the hemolytic anemias. Of course, the CML is in between, and the hematological malignancies come in a big way. Once you rule them out, then you look at any of these causes, right? That's it, I'm done.
Yeah, thank you, ma'am. It was amazing class. I had one doubt coming up. I'm just posting on group. I think he has put. There is some clinical scenario, ma'am. Is written as young female with iron deficiency anemia after transfusion of 4 to 5 hours, fever spike, then indirect hyperbilirubinemia, but no other hemolytic features. DCT, ICT were negative. And next 2 days, patient bilirubin got normalized, HP electrophoresis was normal. The possibilities.
This is nothing to do with this class, right? I was
Yeah.
wondering
Yeah.
where the spleen is going to come. No.
Yeah. Yes. I think more with hemolytic. More
Okay.
with,
Okay. There
but
was
that
an
also,
hemolysis.
yeah.
This could be a transfusion reaction. That's all I
Right.
can say.
Yeah.
I don't think this could be because it's related to the transfusion. We have to link it up to that only.
True. 4 or 5
I don't
hours.
think we can go for a thalassemia or anything like that.
Yeah.
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 As it looks a reaction only rather
Okay.
than anything
One
else
thing
actually.
is a good question. Infection risk in CLL. Yes, infections are possible because it does interfere with the immunity, not because of the lymphocytes are not able to defend, but it is the antibodies. Okay, it's a B cell disease, so that's why you can get patients with CLL can present with infections. Okay, but they're not the first thing that happens to them. Right. when to suspect storage disorders. Storage disorders are diagnosed with exclusion. They are very, very rare. I have seen only one storage disorders in 40 years. So I don't think it's common at all. Okay. So we shouldn't put that as the first diagnosis. When everything else is ruled out, then you've got a pancytopenia and hepatosplenomegaly, then maybe you'll have to do that.
Yeah, mostly they are unsolved case.
Yes, they're unsolved
It
cases.
comes like this only. We are
Yeah.
not finding any reason, and then
Yeah.
I think I discussed this with the endocrinologist. Are you expert of that? Then he told no. so
No,
so
I
no,
also, I mean, I
yeah,
would be out of depth in that.
yeah, no one is expert of this disease. That's
No
what I
one.
am getting messages
Yeah,
that it
yeah.
is
Okay.
not common. So, but mostly what he suggested me to me was even in these cases, your organs are enlarged. On PET, they are not taking much uptake. So
Right.
even though PET uptake is not there, the enlarged organ itself is a indication if you want to go for biopsy, and
Okay.
you have to find something else on by CT or something which
Okay.
can prove, and then by seeing the things, because we don't practice it daily.
No, we don't. Okay. Somebody
Yeah.
asked me a question, can CML present without splenomegaly? Yes, it can. See, the spleen will not come in one day, right? It's going to take time. Okay. So many times, in fact, I think, remember Harrison or somebody, some book says that splenomegaly can be mild and all that. Okay. But whatever we are seeing is always massive. That's why we usually say like that. But you can get, it has to become mild, moderate, then only it can become massive, right? So you can get a C, but unlike, the CLL, which has a big CLL by length of history. CLL is say 10 years, okay, before it becomes a blast crisis. CML is 6 to 8 or 6 months to 1 year before it goes into blast crisis. That's why you don't see that period when this thing is, the count is high, but nothing else is wrong. That you don't see. Okay, I think that answers your question, right?
Yeah. And I think last what I keep repeating, thrombocytosis,
Yeah,
the very good marker to inflammation. But now I do this. It is not absolute, but with thrombocytosis, if you have normal or high hemoglobin,
yeah,
think of myeloproliferative. With
yeah,
thrombocytosis, if you have low hemoglobin, look at the MCV. If
correct,
MCV is low, look at the iron deficiency before thinking much of inflammation. And if
correct.
MCV is normal or high, look at the inflammation more. But
Yeah,
ultimately, first look at the patient.
okay.
So that solves most of the things. Like it is all in
Correct.
the context of patient.
Yeah,
But we do this game of thrombocytosis all the time that, okay, what
yeah,
about HB and then about MCV? And most of the time it gives us idea. See,
yeah,
when arthritis comes to me, and if
right,
thrombocytosis is not much, I'm not that comfortable for inflammatory arthritis.
right,
So
right.
that gives lot of idea. And like I recently saw one case in medical college, PUO,
Yeah,
high count thrombocytosis. Still's disease becomes adult onset still disease becomes very good possibility.
right,
So
right,
there I put lot of emphasis on the platelet count that it helps me there.
right, 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 right.
Yes.
I learned to look at the platelet count in those conditions from you only. Now I
Yeah.
start looking.
Yeah. Thank you, ma'am.
Yeah.
Yes.
Okay.
So we'll
Okay.
conclude, ma'am. And we were more than 100 actually. So if you could
Oh,
not join, I'll share recording soon.
oh, really? Okay.
Yeah.
Okay.
Yeah. It was
Okay.
amazing class, ma'am.
Right,
Yeah.
right.
Yes.
Okay. Okay. Thank you all. Thank you
Yeah.
all for interacting. Otherwise, this class would have fallen
Yeah.
flat. Thank you
Amazing.
all. Thank you
Yes.
all, students. Right.
Sure.
Nice.
Okay.
Okay.
Okay. Will
Right.
I?
Good night.